Good afternoon. I'm Jerry Collins, Chair of the Ethics Committee, the Biomedical Engineering Society, and it is my honor and great pleasure to be able to chair this session. We have three very distinguished people on our panel to discuss inequities experienced by African Americans in healthcare. I'll introduce first Gilda Barabino. Gilda is the president of the Biomedical Engineering Society. In their center, the far end of the table for me, is Dr. Raphael Lee, who is president of the American Institute of Medical and Biological Engineering. And I'll let them take the opportunity to say a few words about their societies or any other words that they'd like to express. In addition to the presidents of our two major societies in the U.S. for biomedical engineering, we have the honor of having attorney Fred Gray with us. Fred Gray is a civil rights lawyer who's been practicing law in his home county of Macon County, Alabama, for over 55 years. He and his wife Carol are with us. Carol is on the third row here, and we're just grateful that they both could come. Fred was legal counsel for Martin Luther King Jr., for Rosa Parks, and for numerous other people who were active and involved in the civil rights movement of the 50s and 60s. Fred intended to be a preacher at one point in his career, but when he came back from law school, Case Western Reserve, he came back, in his own words, determined to destroy everything segregated he could find. And I think the fact that the two presidents of our major societies, our major groups, are sitting here on the podium here, both distinguished African-American scientists, is noteworthy, but we're not where we need to be. Fred was advocate of the survivors of the Tuskegee syphilis study, and there are several books over here that Fred has available for people who would like to have a copy of his account of the Tuskegee syphilis study. He also has a book, Bus Ride to Justice, which is a biographical, an autobiographical book that he'll make available, and he'll be here for signing after the session. It's just a real privilege, as I said, to be on the same platform with these three very distinguished people. And first, we'll let Gilda tell us about her experience with her research and her career.
Good afternoon and welcome. First of all, I'd like to thank all of you for being here. I can't tell you how much of a privilege it is to have this type of session organized here at the Biomedical Engineering Society. This is the first of its kind. It was a pleasure working with Jerry Collins to put this together. We're honored to have Dr. Lee with us and to have Attorney Gray, part of our history and our legacy. And one of the things I want to do, my job right now is to help situate this session. You're in a translational research track, and we wanted to draw attention to racial and ethnic health disparities. And we want to make the connection to why it's important to understand it in a historical context and in the context of the work that we do every day and the lives that we're trying to make a difference in. So you understand translational research is basically bringing basic discovery to clinical practice and ultimately to improve health. And you pretty much have heard the concept of bench to bedside. And when we talk about basic discovery to clinical practice, we often think about the basic discovery from the bench into what we're calling clinical science, and we do clinical trials. But what we don't talk about enough is getting from the clinical practice and the improved health. Like, how do you actually deliver? How do you make sure that all of the people who are suffering are actually gaining and learning and benefiting from the medical discoveries and the innovations that we're all working so hard towards? So part of what we want to draw attention to today is that if we're really going to do excellent translational research, we need to understand the role that race and ethnicity plays in the work that we do. We need to actually take a holistic approach to eliminate these disparities And to do that, we need to work together across disciplines and across areas. We need to include medical science, public health, epidemiology, we need to understand economics, and we need to understand health policies. So this transdisciplinary approach is going to require of us to work together. That means the researchers working with the clinicians, working with the community leaders, and the affected individuals, the patients, the sufferers, the ones who are actually affected with the different diseases who we're trying to help. We have to incorporate real-world considerations. So if you think about it, in the laboratory settings, those are controlled, confined settings when you look at clinical studies with certain populations. But then think about the people in the real world and their environments and where they actually are getting access to treatments or not. So we have to incorporate that in our thinking as we plan the research and as we carry it out and we think about delivery mechanisms. And ultimately, we must be patient-centered. We actually need to hear from the patients that we are working towards making their lives better. They have input as well, and our work would be much better suited to their needs if we heard from them. So I want to draw your attention to a report called Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare. This report was released in 2003. It was commissioned by the Institute of Medicine of the National Academies. And one of the things they reported was that while scientific advances have improved the longevity and quality of life for people in America, these gains have not been experienced equally by racial and ethnic minorities. Further, racial and ethnic minorities tend to receive a lower quality of health care than non-minorities, even when access-related factors such as patients' insurance status and income are controlled. That's powerful. So what's at stake here? There's lots of factors that contribute to health disparities. We're specifically talking about factors related to race and ethnicity. And you can't look at that without looking at and identifying the role of racism. I like some of the work that's been done by Kamara Jones. She's a physician and an epidemiologist at the CDC here in Atlanta. And in some of her articles, she's written that racism is a system of structuring opportunity and assigning value based on social interpretation of how one looks, or race. It's a social construct. And she also defined in an important way categorizations of racism. And she talks about institutionalized, personally mediated, and internalized. And by that, it's drawing attention to, at the institutional level, the kind of systematic lack of access to opportunities for people in society based on race. Personally mediated, meaning things like prejudice and discrimination, or internalized, which can be even more devastating when people who are affected actually start to internalize those negative messages. And all of these factors really do have an impact on how they experience health care. So racism is a major determinant of health and health policy. And I want to draw your attention to two areas in particular: sickle cell disease, which is an area that I have studied my entire career, and I will give you some examples of that, and the Tuskegee study of untreated syphilis in the Negro male, which was 1932 to 1972, and Attorney Gray will talk more about that. But some parallels for these two incidents, or these two situations, are important. One is that there's some parallels in terms of the politics of race in health, the connections between science, medicine, and disease, and also the historical context of race and discrimination in America. And I'm going to draw your attention to how sickle cell disease is an example of that. So in some ways, the two examples that I just gave you are really poignant examples of the problems of when race and politics and science and medicine intersect. Sickle cell disease results from abnormal hemoglobin, where the sickle hemoglobin is from a hemoglobin mutation. It affects 90,000 to 100,000 Americans. And because of the sickle mutation, The red blood cells are sickled in shape. The hemoglobin inside polymerizes, so the cells can't deform readily and cannot pass through the circulation the way normal red blood cells can. This results in decreased oxygen to tissues, and then the tissues become damaged, and then there's a lot of in-organ damage. So patients who have sickle cell disease truly are in deep suffering. Sickle cell disease is also a major public health concern, and I want to draw attention to the pain and suffering in particular and give you some examples how it shows the intersection between race and science and medicine. For many years, and still now, patients with sickle cell disease will go to emergency situations with pain and may or may not get the pain treatment that they need because sometimes the providers think, well, you're just drug seeking. And some of this attitude towards thinking that the patient is drug seeking has to do with racial stereotypes. So the idea that someone would be denied pain medication because of a stereotype is really important. Another thing about the concept of suffering, I like the work of Carolyn Rouse in a book that she published called Uncertain Suffering, which relates the sickle cell disease to racial and ethnic health disparities. And another book by Keith Walu, Dying in the City of the Blues. And in his book, what he did is he traced the history of sickle cell disease, and the setting was the city of Memphis. And he tied it into how the politics of the time and the disease that's affecting predominantly African Americans was really something where you could see race involved, or race impacting how people were being treated or not treated. And one of the things that both of these authors pointed out is it was almost like you had to see that the patients were really suffering and how deeply they were suffering to want to even say, okay, it's okay to provide some treatment for these black people. I mean, it was really those kinds of things that they pointed out in their work. And on the political side and the policy side, it was in 1972 that the Sickle Cell Anemia Control Act was passed. It was a congressional activity. And during that time, there was a lot of black protests going on about rights and so on. And sickle cell anemia became like a symbol of rights and what people should do and in terms of just equal treatment and so on. Part of what came out of the act in 1972 were these congressionally mandated sickle cell centers. And there were 10 of them in the country. They've since been disbanded, and now the way sickle cell research is funded is a slightly different mechanism. But I wanted to share with you, I actually researched in one of those centers for 15 years in Boston. And one of the things that stood out to me as a researcher, and this is why we wanted to share with you our experiences and how this relates to how, as translational researchers, we should understand the people that we are serving. But what stood out to me is when I would actually meet the patients. And there was a mom who had twin boys, and both of her boys, of course, had sickle cell disease. And she was saying to me, just talking to me about the research that I was doing and the commitment that I had, made her more trustful and willing for her son's blood samples to go to my lab for research. But she was reaching out to me. She said she was sick and tired of her children being treated like just dots, you know, like data points, and that people did not understand what the children were going through or what she was going through as a mother of children with the disease. And even now, there's only one FDA-approved drug for sickle cell disease. It's hydroxyurea. And there's so much work to be done. And the last thing I wanted to leave you with before we move on to the next speakers is I just want to bring back home that message about how all of these things are connected. And we need to have an understanding of these issues if we're going to be good translational researchers. So we need an awareness and an increased understanding. Again, we need that holistic and transdisciplinary approach, and we need to be patient-centered. We need to understand real-world considerations. And most importantly, We need a diverse and well-trained set of translational researchers, so that's all of you. So I thank you for your attention. We're going to move to the next two speakers, and then we'll have questions and answers at the end. Thank you.